The current disease in question wasn't picked randomly through a raffle. Rather, I selected it to be sequential to the former video, the antiphospholipid antibody syndrome, as both AFLAS and systemic lupus erythematosus are close by etiology, pathogenesis, and symptoms. In fact, 30 to 40% of systemic lupus patients test positive for antiphospholipid antibodies. So I thought that it will be proper to present them in sequence. This will be the current coverage. I will go through these slides to explain the content before I will leave you alone to study the slides by yourself at your chosen pace and space. I start by listing the lupus types that have acute, subacute, and chronic courses, of which only the first one, the systemic lupus erythematosus, will be discussed, as that is what matters to pregnancy. First, let's define it. Name it, claim it. SLE is a systemic chronic autoimmune disease with manifold inflammatory damage of connective tissue in the joints, synovial membranes, cartilages, vessels, skin, brain, and internal organs. The course of this disease can be sporadic and unpredictable, but it's typically characterized by periods of relapse and remission. The relapse is known as lupus flare. The global distribution of this disease is indeed chaotic. Below are the incidence data collected from various countries. Some are directly taken from the country reports, and some are the pooled mean estimates from multiple reports. Bear in mind that not every country has a reporting system that passes the integrity or accuracy tests. With all that complexity, Europeans are the least affected by SLE. Here I show the survival rates and the instruments used to measure the SLE activity. Next, the etiology is multifactorial. Pathogenesis has complex interpreting. Further, I show the diseases that must be distinguished from SLE and the clues to differential diagnostics. Here I show the effects of SLE on pregnancy and the mechanisms of its action. Frequent scanning for fetal growth restriction is mandatory, and fetal echocardiography referral should be arranged for those with anti-nuclear antibodies if any cardiac abnormalities are detected on the ultrasound scan. Heightened attention is required for preventing cardiac block in the fetus because the anti-nuclear antibodies of SLE cross the placenta and damage the atrioventricular node of the fetus or the Purkinje system. So the trick is that pregnancy by its nature can mimic SLA symptoms. To understand whether there is an SLA flare, in particular nephritis, serum creatinine must be checked in dynamics. Also, one needs to appreciate that SLE flares can occur without those affecting pregnancy. The next two slides give a comprehensive picture of the antenatal screening protocol, including the careful use of steroids in pregnancy, when and how. Then comes the legal section, where I present 2 malpractice cases followed by 8 authentic review questions, both medical and legal. The answer key is provided on slide 21. Here I'll leave you to study the slides on your own.